Thanks all of you for joining us on this post-Thanksgiving discussion of neurogenic obesity after spinal cord injury. We're going to continue on with some of the things that we've already put together, but specifically I'm going to talk you through the pathophysiology of spinal cord injury and discuss why that pathophysiology plays into the development of neurogenic obesity and metabolic syndrome in persons with spinal cord injury. We'll talk about energy metabolism, dietary strategies, as well as exercise interventions specific to mitigate obesity after spinal cord injury. So just as a reminder, the central nervous system is comprised of the brain and the spinal cord. As we go down different levels of the spinal cord, we investigate the somatic nervous system, and we know that at approximately 1 centimeter intervals as we move down, we will have influence on nerve roots that serve specific dermatomes and specific myotomes. So the somatic nervous system is well represented on this slide. We also need to take into account that the sympathetic nervous system particularly arises from the thoracolumbar regions of the cord, and so interruptions of the cord along this level could significantly blunt sympathetic influences. Similarly, the very lowest levels of the cord contribute to the parasympathetic nervous system control of the bowel and bladder. So I want to briefly just remind you of the components of I'm going to talk specifically about the cord, recognizing that only 10% of the spinal cord actually conducts neural impulses. And in fact, about 90% of the contents of the spinal cord are glial cells that provide support, nutrition, and protection for those neurons. So briefly, these are all bundled together in a way that allows very separate communication with efferent information going from the brain down the cord to the rest of the body, as well as afferent information. And those bundles basically are well insulated so that there's no crosstalk amongst those. And as we look at the cord itself, recognizing that we have efferent impulses that are descending the cord in very specific tracks, as well as afferent information ascending the cord, taking information to the brain itself. And again, at about 1 centimeter intervals, we have afferent information coming in along nerve roots, as well as efferent information going out, and those are modulated to some extent by interneurons that can be facilitatory or inhibitory. And so damage, and again, this is a very simplistic cartoon, but damage to a region of the cord that is about as big around as your little finger, you're going to have significant disruption of all of those descending, ascending tracks and interneurons as they're coming through. So why is this a big deal? Well, it's going to be really hard to cure paralysis. And the folks here in Miami have been on this mission for at least the last 30 years. And there are folks across the world that are looking to this. Why is it so difficult to restore neural influences after a spinal cord injury? Well, first, there is an area of necrosis because of ischemia and infarct to the regions of the cord. This area subsequently becomes somewhat of a chasm in 360 degrees. And so one of the first things that you'd have to do to develop communication above and below the level of the injury is to break through the glial scar that is present in a 360 degree array around the area of injury. But let's say that we found a way that we could break through that glial scar above and below. We still have a pretty significant gap in here. And so over the years, we've tried a number of different things. Most recently, there has been some artificial scaffolding that has been put together, but in the past they've tried to use Schwann cells or stem cells. The bottom line is we can develop a way to provide a scaffold across this chasm, if you will. But even were we to do so, we still have problems with a number of inhibitory proteins that become abundant after spinal cord injury. And those include the no-go proteins, the myelin-associated glycoproteins, tumor necrosis factor alpha, and nuclear factor kappa B. Let's say that we could, in fact, find a way to build a bridge and actually hold hostage those inhibitory proteins. We still have to recognize that a new neural cell developing is going to require specific growth factors at specific concentrations and specific times in its development. So let's say that we could also put together a cocktail that had all of those growth factors present in it. We still have an issue with regard to directional guidance of those new nerve cells as they go through there, so that they connect appropriately with the afferent and or efferent cells that they're supposed to hook up with. If they don't connect appropriately, then you're going to have significant misfirings throughout the neural system. And we see that specifically as spasticity, neuropathic pain, and a number of things that are difficult. So all of that to say, we don't have an immediate answer to curing a spinal cord injury. We're going to continue to look, but in the interim, we have to consider, what our individuals with new spinal cord injury are going through. So I want to share a case with you. This is a 24-year-old Army Ranger. Didn't have any significant past medical history. Those of you not familiar with the Rangers, these are the best of the best. They are incredibly intelligent and physically fit, incredibly strong, fast, and with a great deal of endurance. So this is pretty much, the optimal specimen of a man in our society, at least in terms of physical abilities. This young man, unfortunately, took a bullet to the neck that resulted in a C4 burst fracture. He subsequently underwent C3 through C6 laminectomy and a posterior spinal fusion for that injury, but was subsequently left with C4 Asia Impairment Scale A tetraplegia. He also had a mandibular fracture from where the bullet went through his jaw. He came to us from overseas on mechanical ventilation with a tracheostomy, a feeding tube, and unfortunately a grade 3 sacral pressure injury. So this young man went almost immediately from this perfect physical specimen to an individual with complete tetraplegia. Now, as we look at his energy requirements as he came to us, the nutritionists in the hospital at the time basically used the Harris-Benedict equation to determine what his energy needs should be. And so 24 years old, 160 pounds, 6'1" with a complete C4 spinal cord injury, his predicted basal metabolic rate was 1,827 calories a day. In the Harris-Benedict equation, you make a correction for that, particularly in a trauma patient, so that his predicted energy needs were 2,900 calories a day plus change. I was a little concerned that this might be overfeeding him. We actually looked at his resting energy expenditure at this time, which was found to be 1,280 calories a day. So this represents basically a mix or a mismatch of 1,643 calories a day that would contribute to a positive energy balance. How positive? So he's going to gain approximately 11,500 kilocalories per week, and over the course of a month would have gained close to 50,000 calories. That is accumulation of 14 pounds of fat over 4 weeks. So we recognize that this perfect specimen of a man now with a spinal cord injury, has a number of comorbidities besides his paralysis that contributes to neurogenic obesity. And that's where I'm going to spend the rest of my time in discussion. So we recently published a whole journal volume on neurogenic obesity after spinal cord injury. We know that it is at epidemic proportions in persons with spinal cord injury. Neurogenic obesity reflects excess body fat, that is more than 22% body fat for men or 35% body fat for women because of motor paralysis and obligatory sarcopenia, sympathetic blunting, anabolic insufficiency, and blunted satiety, which is essentially you don't realize when you're full. Subsequently, folks with spinal cord injury almost always take in more calories than they expend. And so they subsequently store those calories as adipose tissue. That adipose tissue mediates metabolic syndrome, causing insulin resistance, hypertension, dyslipidemia, thromboembolism, and coronary artery disease. So I'm going to spend the next several minutes kind of talking through each of those aspects. So way back in the early 90s, Rodriguez out of New Mexico took a look at the energy and protein requirements of trauma patients. And she compared trauma with spinal cord injury as opposed to trauma without spinal cord injury. For each group, they provided 120% of their predicted energy expenditure in terms of calories, and also provided plenty of protein, more protein than is usually provided in the diet, 2.4 grams of protein per kilogram of ideal body weight per day. And what she found was basically these folks continued to lose nitrogen even up to 2 months out from the spinal cord injury on this diet, whereas individuals with no spinal cord injury but trauma achieved nitrogen balance within 3 weeks. They repeated this study 5 years later and had very, very similar findings. One thing they stressed as they concluded that particular paper was that it's inappropriate to use these predictive energy expenditure equations. But if they are to be used, certainly you don't want to include these multiplier correction factors. And why is that? Because of an obligatory sarcopenia. The person is going to lose a significant amount of muscle mass because of the paralysis. They're also going to lose a fair amount of bone mass for similar reasons. And therefore, their resting energy expenditure is going to be markedly diminished after spinal cord injury. So now we have a situation in which we have significant loss of muscle mass and bone mass. And I want to talk through a little bit about the sympathetic blunting now that also contributes to a reduction in energy expenditure. So recall that under any given time, our body is at a tug of war between the parasympathetic nervous system and the sympathetic nervous system. The sympathetic nervous system is about fight or flight. It's mobilizing substrates to address an emergency or crisis situation, whereas the parasympathetic nervous system is responsible for resting and digesting, replenishing all of those substrates and whatnot that were used during the crisis so that the body has those available for the next crisis situation. So following a high spinal cord injury, and I'll say high thoracic or cervical spinal cord injury, we see a significant reductions in catecholamines and a subsequent reduction in heart rate, blood pressure, and body temperature, reflecting that. We also lose some of our anabolic potential simply because we're not activating muscle anymore. And so we see marked decreases in testosterone after spinal cord injury and free testosterone in particular. There have been a number of studies looking to provide testosterone replacement, and that is appropriate. However, if the person is not activating muscles, there is a slight increase in fat-free mass, but otherwise we we don't see a significant change in body composition without adding exercise to the testosterone replacement strategy. So recognize there are some contraindications. So those individuals with testosterone replacement may be at higher risk for benign prostatic hypertrophy, prostate cancer, and breast cancer. And they are likely to reduce their endogenous testosterone production. Also recognize that providing higher levels of testosterone will likely decrease the high-density lipoprotein cholesterol and increase the low-density lipoprotein cholesterol. So we'll speak to that in just a few moments. I want to really hone in for a moment on the relationship between resting energy expenditure on the y-axis and fat-free mass on the x-axis. There is a very tight relationship between the two, such that this holds true for children, for young adults, for the elderly. It holds true for men as well as women. And so Wang put together this, this equation way back in the day, looking at resting energy expenditure using an equation that basically looked at fat-free mass. It doesn't hold true specifically for spinal cord injury, but it does get us into the ballpark. We know that there's also blunted satiety. I mentioned earlier, folks, for a number of potential reasons, simply don't know when to stop eating. And part of this is thought to be a blockage of the factors that would typically inhibit a person to continue eating. And so we are actually going to be looking at that in our laboratory in the very, very near future. Dr. Farkas has a study that we're going to be moving forward with. So the bottom line is, for our folks with spinal cord injury, we almost always see energy intake exceeding energy expenditure. And this results in a positive energy balance that is stored in the form of adipose tissue. So what? It's not just stored tissue that we have to recognize now. There are a number of different components to adipose tissue. And we know that some locations of the adipose tissue is especially causing some of the morbidities, whether the person has spinal cord injury or not. So visceral adipose tissue, subcutaneous adipose tissue, intramuscular adipose tissue, and marrow adipose tissue all increase after spinal cord injury. And as we reported out in that volume on neurogenic obesity, this puts our folks at particularly high risk for a number of different factors, including, and we will talk through the pro-inflammatory cytokines. There's going to be insulin resistance, hypertension, and dyslipidemia associated with this. And our folks, while this is, I don't know that this has been reported in the literature, but I suspect that our folks with spinal cord injury are going to have a very, very high degree of fatty tissue in the liver. So this is another area for investigation. So those pro-inflammatory cytokines that I talked about, there are several that basically contribute to those issues of insulin resistance, hypertension, dyslipidemia that I talked about earlier. Tumor necrosis factor alpha is produced by adipocytes and stromal macrophages. We know that tumor necrosis factor alpha specifically suppresses insulin receptor substrate, that's IRS1 and 2, as well as glucose transporters, so the GLUT4 transporters. We also know that tumor necrosis factor alpha upregulates the suppressor of cytokine signaling 3, so SOX3, and induces pancreatic beta cell apoptosis. Remember that the beta cells in the pancreas are where we produce insulin. And so TNF alpha actually causes cell death of those insulin producing cells. Interleukin 1B, also produced by adipocytes, also induces pancreatic beta cell apoptosis via nuclear factor kappa B. IL-6, interleukin 6, is produced by both adipocytes and stromal macrophages. It also suppresses IRS1, IRS2, and GLUT4, and upregulates SOX3. Monocyte chemoattractant protein 1, MCP1, produced by adipocytes and stromal macrophages. This actually attracts more macrophages and monocytes, other immune cells, to the vascular subendothelial space, where we see additional damage occurring in the development of foam cells, so that we end up with narrower and narrower lumens for the arteries. And then finally, nuclear factor kappa B, light chain enhancer of activated B cells, nuclear factor kappa B, it is activated by TNF alpha, IL-1B, and IL-6. We know that nuclear factor kappa B blocks phosphorylation of IRS1 and IRS2. It inhibits the PI3 kinase cascade system that is required to activate GLUT4 migration to the cell membranes, and so essentially contributes to insulin resistance. We know that there is this tight relationship between obesity and immunosuppression. I'm not going to go into that in detail, but I would encourage you to read Ona Bloom's recent manuscript in experimental neurology about this relationship between obesity and immunosuppression, pro-inflammatory cytokines. Just as a reminder, when we keep talking about insulin resistance, we have multiple cells in the body, but specifically skeletal muscle and liver cells. And this is what those cells look like. They have a cell membrane. On the cell membrane, they have receptors for insulin. So this is insulin receptor substrate 1 and 2. And that needs to be activated in order to mobilize the GLUT4 receptors that sit in the cytoplasm of the cell to migrate to the cell membrane and allow passage of glucose into the cell. What does that look like? So as you increase glucose in the vascular tree, it stimulates the release of insulin from the beta cells of the pancreas, and this activates the PI3 kinase cascade and allows for migration of the GLUT4 receptors to the cell membrane and the passage of glucose into the cells. So that when we look at how adipose tissue interferes with this whole process, there are a number of different mechanisms, and in fact, 8 different mechanisms that are played out here by which adipose tissue causes insulin resistance. I don't have time to go into the full details of that today, but we did describe it in our recent manuscript. We know that there is, in fact, reported insulin resistance in persons with spinal cord injury. Bauman and Spungen and Bauman's group in the early and late 90s reported out hyperinsulinemia and impaired glucose tolerance in persons with spinal cord injury, worse in those with tetraplegia as opposed to paraplegia. We reported out in 2006 individuals thinking 20% of those spinal cord injury veterans that we looked at reported that they had been given a diagnosis of diabetes mellitus, typically type 2. We reported out in 2019 approximately 50% of 477 veterans had fasting sugars greater than 100 milligrams percent or were under treatment for insulin resistance. And then just this year, we reported out in 72 individuals, and we were looking at the gold standard for body composition assessment. 72 individuals, 32% had sugars greater than 100 milligrams percent or were under treatment for diabetes. So we know that insulin resistance is a major problem. We know that it's caused primarily by adipose tissue. There are a number of ways that we approach managing diabetes. Typically we will start off with metformin, according to the guidelines that have been provided by the American Diabetes Association. There are other things that we can look at as well. We have to be cognizant, however, that if we provide insulin sensitizing agents, that is going to get your blood sugars down. It does that by taking blood sugar into the cells where it's converted to adipose tissue. And therefore, this can be a problem. And most of the time, as we start somebody on these insulin sensitizing agents, we do see a gain in body weight, and particularly fat weight, because of that very thing. So as we treat diabetes, we have to recognize we are not just treating the blood sugar, but we need to be treating the overall energy expenditure for that individual as we move forward. We also know that adipose tissue causes dyslipidemia. So part of this is because of the insulin resistance. Recognize that as you develop insulin resistance, you also increase adipose tissue lipolysis, causing a hypertriglyceridemia and an increase in non-esterified free fatty acids. So as those non-esterified free fatty acids, triglycerides increase, and particularly in the portal circulation of the liver, we see an increase in apolipoprotein B, that is ApoB, as well as the low-density lipoprotein cholesterol and very low-density lipoprotein cholesterol. These are the bad portions of cholesterol that contribute significantly to poor health. We also see, as you increase these non-esterified fatty acids and triglycerides, a reduction in apolipoprotein A, ApoA, and a decrease in our high-density lipoprotein cholesterol, which is the good cholesterol. And then finally, as if that wasn't bad enough, so we have less high-density lipoprotein cholesterol to help clean up or scavenge all of these lipids in the vascular tree. We also see an increase in cholesterol ester transfer protein associated with adipose tissue. So this promotes triglyceride exchange with the cholesterol esters between the lipoproteins and renders the remaining HDL cholesterol dysfunctional. And so you have a reduction in HDL cholesterol, and of that remains, a good portion of it is simply dysfunctional. So you're going to have a significant dyslipidemia. Often, you're going to see normal total cholesterol levels, as reported out by Bauman. Therian as well in the late 90s showed that 60% of individuals with spinal cord injury had low HDL cholesterol. That is less than 40 milligrams percent for men or 50 milligrams percent for women. And then Bauman and Expenditure reported out in 2007, about 2/3 of individuals with spinal cord injury have HDL cholesterol less than 40 milligrams percent, putting them at high risk for dyslipidemia. We reported out in, again, that veteran manuscript, close to 70% of our individuals with with spinal cord injury had HDL cholesterol less than 40 milligrams percent. And most recently, we reported out in that cohort of 72 individuals, 85% of the men and 77% of the women had low HDL cholesterol levels. So again, we've got a problem as we look at this adipose-mediated hypertension. Briefly, I'm sorry, I skipped over a slide there. What I wanted to say is have problems with dyslipidemia. Now, they also have problems with hypertension, and this is mediated primarily through adipose tissue. Part of this is because of a leptin resistance. Remember, leptin has something to do with appetite suppression, but as you accumulate more and more adipose tissue, you become resistant to leptin. We also know that there is a sympathetic nervous system activation, both with muscular SNS activity as well as renal SNS activity. We know that the renin-angiotensin-aldosterone system is also going to be activated because the adipose tissue secretes these modifiers to cause vasoconstriction. It also inhibits nitric oxide release. Remember, that's a vasodilator, so you have a relative vasoconstriction without that, and stimulates the release of aldosterone to increase sodium and fluid retention, all of which contributes to hypertension. But there's more. Natriuretic peptide catabolism is also altered as you increase adipose tissue. And then you have renal compression simply because of the amount of fat surrounding the the abdominal organs. And then finally, we've talked a little bit about arterial sclerosis. As it occurs, you have stiffened blood vessels, and that subsequently leads to hypertension as well. So we have seen this reported in 2007. We looked at close to 8,000 veterans, and surprisingly, a number of them had blood pressures between 120 and 139 systolic, or 79/89 diastolic, and close to 25% of them had blood pressures greater than 140/90, and we verified that this was not autonomic dysreflexia. Barry in 2013 reported out 57% of 6,600 individuals with traumatic spinal cord injury had hypertension, as opposed to non-spinal cord injury controls. 72% of some 3,500 veterans had hypertension as well, compared to a matched non-spinal cord injury control group. What we found in our group of 473 veterans, 55% of them truly had hypertension. And again, most recently, 43% of 72 individuals had hypertension. And about a quarter of those were individuals with tetraplegia. So this was, remember, those folks should have neurogenic hypotension. So as we talk about metabolic syndrome, it incorporates, depending upon which definition you're looking at, incorporates some combination of visceral fat, adipose tissue, as well as some degree of dyslipidemia, hypertension, or insulin resistance. So the International Diabetes Federation definition, typically they have used waist circumference. We used surrogate markers as we looked at our veterans with spinal cord injury. So again, 473 individuals with a mean age of 56, almost 20 years out from their spinal cord injury, and about 50% of them had tetraplegia. 3/4 of them were obese, using the surrogate BMI of 22 kilograms per meter squared. More than 2/3 had low HDL cholesterol, 50% had fasting blood sugars greater than 100 milligrams percent, and 55% had hypertension. So by the International Diabetes Federation definition, 57.5% of this veteran cohort has metabolic syndrome. Now, I need to bring this up as well. When we look at just body mass index, we know that it underestimates obesity and spinal cord injury. Buchholz up in Canada reported out those individuals with complete paraplegia, their total daily energy expenditure was just over 2,000 kcals a day, compared to individuals without paraplegia who had total daily energy expenditure about 500, 600 calories a day more than that. Jones reported out in 2003, lean body mass was significantly reduced in individuals with spinal cord injury compared to able-bodied controls, and their fat mass was significantly higher by about 7 kilograms. Bauman did a really exquisite study looking at total body potassium in twins, one of whom had a spinal cord injury and one who didn't. And they found significantly lower total body potassium, which reflects muscle mass, in the individual with spinal cord injury compared to their monozygotic twin. And then Lawton used bioelectric impedance analysis in 2009, basically suggesting that a BMI greater than 22 seemed to put folks at high risk for obesity in the spinal cord injury population. And this was also associated with higher levels of C-reactive protein. What we reported out was with a BMI of 27.3 kilograms per meter squared, we had about 42% body fat on average in our individuals with spinal cord injury. So how do you go about doing body composition assessment? Essentially, you take the body and you strip it down to its respective components of muscle mass, bone mass, and fat mass. So there's a number of different ways that you can do that, including underwater weighing, skin fold and anthropometry, DEXA, You can use air displacement plasmography as opposed to doing underwater weighing. You can do bioelectric impedance analysis, or you can just look at body mass index. The problem is when you look at BMI for persons with spinal cord injury, and then you look at their percent body fat, a BMI of 25 kilograms per meter square is equivalent to about 35% body fat, and this is both men and women. And so we have a major problem if we're going to use BMI as a surrogate marker of obesity. So the gold standard to determine body composition is the 4-compartment model that employs underwater weighing, DEXAs, and deuterium dilution or bioelectric impedance analysis to separate the body into compartments that include fat, total body water, bone, and residual dry mass. We just reported out on the comparison of different ways of looking at body composition assessment in persons with spinal cord injury. And again, a BMI of 27.3 translated to 42% body fat. We were also able to come up with a predictive equation using a combination of age, sex, weight, and the abdominal skin folds. And we put together these equations for both men and women. And so more information on that is available, but I don't have time to go into it in detail now. I want to talk about this most recent study that we have reported, looking at 72 individuals with motor complete spinal cord injury. We had 59 men and 13 women. Almost 3/4 of them had paraplegia. We were looking at individuals with levels of injury between C5 and L2. The mean age for this cohort was 44, and they were about 14 years since or out from their spinal cord injury. If you looked at just the BMI surrogate for spinal cord injury greater than 22 kilograms per meter squared, 82% of the individuals that we looked at by this criteria would have been reported as obese. However, when we looked at 4-compartment modeling, we found that actually 97% of the individuals for men had more than 22% body fat, or for women more than 35% body fat. So 83% had dyslipidemia or were under treatment for dyslipidemia. 32% had fasting blood sugars greater than 100 milligrams percent or were under treatment for diabetes. 43% had hypertension, that is a systolic blood pressure greater than 130 or diastolic pressure greater than 85 or under treatment, meaning that 60% of this cohort had metabolic syndrome by the International Diabetes Federation criteria. So what are the resting energy requirements for any of us? We know that it's a combination of energy that is needed for the liver, the heart, the kidneys, and brain, although I'm sure those listening on the call today have much more of their energy expenditure burning by the brain. We know that skeletal muscle is the most variable of these components, contributing to resting energy expenditure. There is a compendium of physical activity that has been put forward by Barb Ainsworth back in the 80s, I believe it was. And in looking at our folks with spinal cord injury, we realized that we really didn't have a similar compendium for persons with spinal cord injury. So we did a VA cooperative study between the Hines VA in Chicago, Ann Arbor VA in Michigan, and the Palo Alto VA. And we looked at 50 different activities, estimating caloric expenditure for those activities, and basically reported out energy costs with spinal cord injury, very much determined by the level of spinal cord injury. Now, as a whole, when we talk about a metabolic equivalent, it's recognized that in the general population, a single metabolic equivalent means that you're burning 3.5 milliliters of oxygen per kilogram per minute. And we found that as we averaged our folks with spinal cord injury, they had significantly lower one metabolic equivalent, that is equivalent to 2.7 milliliters of oxygen burned per kilogram per minute. And we found that folks with higher levels of injury burned fewer calories for similar tasks. So let's talk through the components of total daily energy expenditure for a moment, recognizing that 60 to 75% reflect resting metabolic rate. The thermic effect of activity is contributing to approximately 15 to 30% total daily energy expenditure, and even the thermic effect of a meal. So when you eat, it takes calories to digest that food. What we find as we look at individuals with spinal cord injury, an able-bodied individual, and let's use myself as an example, with my height, weight, and age, my total daily energy expenditure is around 2,800 calories a day. If I was to sustain a spinal cord injury, and let's be generous and say it was paraplegia, if I had motor complete paraplegia, my total daily energy expenditure would drop by about 25%. If I had tetraplegia with a higher level of spinal cord injury, my total daily energy expenditure would drop by half or even more than that. And that is contributed to by lower basal metabolic rates, the thermic effect of physical activity, as well as the thermal effect of food. So how do we measure energy expenditure? Ideally, we use direct calorimetry in a metabolic chamber. There are very few of these available in the world, and unfortunately, I think only 2 in the United States. So that's not very practical. We could do indirect calorimetry, where we look at oxygen consumption and recognize that converting 1 liter of oxygen to about 5 kcals is how we look at that. We can also look at the relative substrate utilization in the body if we compare oxygen consumed and VCO2 produced. And that gives us an idea that, so carbohydrates, for example, if you're at rest and your respiratory quotient, that is the ratio of the VCO2 relative to the VO2, is 1.0, you're just burning carbohydrates. If you're at total rest and you are not burning any carbohydrates, you only had fats, then your respiratory exchange ratio would be 0.7. All of that to say, we can figure out quite a bit by looking at indirect calorimetry. However, when we look at the accuracy of estimated and measured resting metabolic rates after spinal cord injury, we see a significant mismatch looking at these measured versus estimated energy expenditures. We do feel that indirect calorimetry is therefore essential to determine at least the resting metabolic rate for spinal cord injury. We also know if we look at basal metabolic rate, now basal is going to be a little bit lower energy expenditure than resting because basal reflects simply the calories required to maintain life completely at basal metabolism. So there have been equations, and in fact, we developed an equation where we used that 2.7 milliliters of oxygen per kg per minute as a metabolic equivalent compared to able-bodied individuals. And we can take the total daily energy expenditure equation for able-bodied individuals, which is BMR times 1.2, and convert that to use for persons with spinal cord injury. And essentially, the equation translates to BMR times 1.15. We reported this out in 2019. I want to talk a little bit about exercise after spinal cord injury. We recognize that there are a number of comorbidities that we have to address when we're prescribing exercise, but we've put together, and this has been done over many years by a number of different groups, guidelines for putting together an exercise prescription for somebody with spinal cord injury. You can look at aerobic exercise, strength and power exercise, and then exercise for flexibility. The bottom line, however, is as we look at exercise for spinal cord injury, what has been reported out has been changes in aerobic fitness, changes in anaerobic fitness, strength levels, and physiological changes. Those are fairly dampened compared to the able-bodied individuals. And physiologically, our folks with spinal cord injury just can't, we don't see the changes after 3 or 4 months of exercise that we would see in persons with spinal cord injury, or at least those changes that occur are relatively minimal. So at least in my mind, I wonder if we haven't been prescribing exercise inappropriately. And in fact, what we need to be looking at is, can we use exercise to achieve a negative energy balance after spinal cord injury? And so if you think back to the iRobot definition, we have to be asking the right questions, I think, to be able to move forward with this. So we currently have underway an NIH trial looking at ways to reduce obesity after spinal cord injury. What I want to use kind of as a foundation or a starting point, however, is we compared arm crank ergometry previously with functional electrical stimulation leg cycle ergometry to see if we could significantly change body composition, insulin sensitivity, glucose effectiveness, and VO2 peak. We were also looking at lipid profiles, et cetera. And what we found when we compared groups, those that were doing arm crank ergometry as opposed to those with FES, both groups significantly decreased percent body fat as well as systolic and diastolic blood pressures. And both groups increased fat-free mass, increased HDL cholesterol and energy expenditure per session, but both groups also gained body weight. And so functionally, if you still have more body weight, you're going to have more difficulty getting around in the usual environment. And so as we look through the literature, and again, there have been a lot of reports. Most recently, Warburton put together a very comprehensive review looking at exercise for spinal cord injury. And Warburton's group recommend FES training, a minimum of 3 days per week for 2 months to improve muscular endurance, oxidative metabolism, exercise tolerance, and cardiovascular fitness. They also recommend that aerobic and FES exercise training can clinically improve glucose homeostasis and lipid lipoproteins, and that body weight supported treadmill training can improve indicators of cardiovascular fitness. And this is both for tetraplegia as well as paraplegia. We reported out recently exercise interventions to target obesity in persons with spinal cord injury. And again, what we are coming to realize is that we have to consider energy balance as we do that. And so a typical exercise prescription is going to include the person's spinal cord injury and completeness and the comorbidities that I've talked through. Probably the most important part of prescribing exercise for a person with spinal cord injury is what are their goals. And then we're going to try to match our testing as well as our training protocols to their specific goals with that. So looking at mode, frequency, intensity, duration, and progression. Now, the current guidelines that are out there say that individuals with spinal cord injury need to exercise at least 150 minutes per week. However, I think as we have looked more closely at those guidelines, we feel that it's unlikely that folks are going to see significant benefit from 150 minutes per week at the level of exercise that is recommended by the American College of Sports Medicine. Simply, they can't achieve that level of intensity because of physiological limitations. So we can look at total daily energy intake and compare the caloric densities of the foods that the individuals are taking in. We have recently looked at nutritional status in persons with spinal cord injury. And the bottom line is if what they report is accurate, and we look at their resting metabolic rate of approximately 1.15 times resting metabolic rate, what we find is that generally these folks are going to be gaining somewhere around 16 pounds of adipose tissue per year. So the recommendations using the old food pyramid still are that we encourage the consumption of green vegetables, raw vegetables, beans and legumes, tomatoes, fresh fruit, peppers, and mushrooms. And try as much as possible to limit flour, sugar, oil, and alcohol consumption. Maybe the Mediterranean diet is the place we need to go unless the energy intake associated with Mediterranean diet still exceeds their energy expenditure. So we don't know the best constellation of diet yet as we consider summarizing the attempts to decrease obesity and spinal cord injury. We recognize that we need to look at body composition, we need to look at total daily energy expenditure, and then we need to modify diet and exercise in order to achieve a negative energy balance. We recently published the cardiometabolic risk associated with spinal cord injury. Dr. Nash chaired that panel, which demonstrated individuals with spinal cord injury are high risk for cardiometabolic disease because of obesity, diabetes, hypertension, and dyslipidemia. And the recommendations of the panel were to alter nutrition and physical activity and then use pharmacotherapy as necessary. These were risk factors that we identified, and defining levels of high risk were put forward here. And what we found in our folks with spinal cord injury is there is a large portion of the population that truly has cardiometabolic syndrome. Very conservatively, at least a third of individuals, and by our recent investigations, I would say somewhere upwards 50 to 60% of folks truly have metabolic syndrome. So what should our screening practices look like? And the bottom line is at least once a year, we need to assess the individual for diabetes, for obesity, for dyslipidemia and hypertension, at least once a year. Blood pressure should be looked at routinely at every visit to the physician. The risk factors that lifestyle contributes to this is suboptimal nutrition and physical deconditioning. And so we also need to try to modify those things. Again, pharmacotherapy certainly needs to be employed for dyslipidemia and hypertension, as well as insulin. However, recognizing that, again, if we are using insulin sensitizing agents, we're going to increase the blood sugar is going to decrease as we get it into the cells. But as we get the sugar into the cells and meet our diabetes recommendations, we are essentially increasing adipose tissue unless we alter intake and expenditure. Bariatric surgery is used by those individuals in the able-bodied population. We do not recommend it, only as a last resort for persons with spinal cord injury because of neurogenic bowel bladder that could be affected by this type of a surgery. So we have, as I mentioned, ongoing research here at the University of Miami in the Christine E. Lynn Rehabilitation Center for the Miami Project to Cure Paralysis. We're looking at spinal cord injury, exercise, nutrition, conceptual engagement. So this science project basically is looking at the use of functional electrical stimulation, leg cycloergometry, and nutritional intervention that is home-based to see if we can improve body composition, insulin resistance, to improve the lipid profiles, and hopefully reduce hypertension associated with this. Most recently, in fact, just last month or the month before, we had a very comprehensive review of energy expenditure and nutrient intake after spinal cord injury and put together some practical recommendations, recognizing that generally speaking, our folks with spinal cord injury have low energy expenditure, which puts them at high risk then for accumulating fat, and they have a high caloric intake, which also puts them at high risk for developing or developing obesity and adipose tissue. So we put together dietary recommendations and activity guidelines. A lot of work that needs to be done in this area. We do know that this is a growing problem in our folks with spinal cord injury. We know that adipose tissue is the central mediator of the metabolic syndrome, and our treatment options really need to include a strong component of behavior modification and pharmacological intervention as we go through there. So I have used up most of my time. I do have some references, and we have a couple of minutes left for questions, if there are questions out there. So I will stop sharing my screen and see who is left on the call. Questions, thoughts, concerns, gripes, and groans. So I've got two of our really great investigators in this issue on the Zoom call with me at the moment. Dr. Farkas has looked at exercise, has looked at energy expenditure. We're working with Elisa Snage, who's also a postdoc in my laboratory, to see what we can do to improve diet, improve exercise to the point of modifying body composition in this very vulnerable population. Not seeing any questions, not hearing any questions. I'm going to go ahead and give you back a couple extra minutes of your day. Thank you for listening in. Feel free to reach out by email at dgater, G-A-T-E-R, at miami.edu. If you do have questions and are just a little bit shy about getting them answered. So everybody have a great day. I'll be back in a couple of weeks to do the next lecture.